Well, hello and welcome back to class. This is Applied Anatomy and Physiology, AAP 301 for the College of Natural Health Sciences, Bermuda. My name is Dr. Delcina Bean Burrows, and this is lecture number 16, where we will be discussing the reproductive system. In today's lecture, we will be taking a look at the learning objectives, the key terms, common structures and physiology, male reproductive system, female reproductive system, pregnancy and childbirth, and aging and the reproductive system. And before we get started, just a brain exercise here. Why do you think the heart rate of a fetus slows when a mother rubs her belly or talks? At what point might a pregnant person feel the baby move? The learning objectives for today's lecture are that at the completion of this lecture, you will be able to explain the function of the male and female reproductive systems and discuss their relationship and importance to manual therapy practices, list the structural features and hormonal control processes that the male and female reproductive systems have in common, name, locate, and explain the general function of the male genitalia in terms of primary and accessory reproductive organs, name, locate, and explain the general function of the female genitalia in terms of the primary and accessory organs. Describe the stages and hormonal regulation of the female reproductive cycles. Explain the key physiological processes that occur during each stage of pregnancy and childbirth, and discuss the reproductive system changes that occur as the body ages. Some of the key terms that we will note today are the amniotic sac, the blastocyst, conception, ejaculation, embryo, erection, estrogen, fertilization, fetus, gamete, gestation, implantation, labor, menstrual cycle, ovulation, ovum, placenta, progesterone, semen, sexual reproduction, sperm, and testosterone. Let's begin our lecture today by considering the common structures and physiology of the reproductive systems. Like all living organisms, humans possess a biological need to reproduce. In humans, this need is driven by specific hormonal changes. Sexual reproduction is the process in which one male sex cell and one female sex cell join. The sex cells from each parent, called gametes, carry half the genetic code for an offspring. When joined, a complete, unique DNA blueprint is formed. This single cell divides and differentiates to create a new individual who may share some similar qualities with the parents, but does not duplicate either one. The human need to reproduce is a powerful and complicated process due to connections between the pleasure centers of the brain and the endocrine structures that control reproduction. It can be driven by a desire for sex, which is the libido, or overpowered by lack of desire. In the same way that emotions and other factors influence eating patterns, libido is deeply affected by memories, emotions, values, thoughts, and beliefs. This makes sexual desire and reproduction part of the much larger marvel and mystery of life. While the organs and processes of the male and female reproductive systems differ, they share a few common features. The primary reproductive organs are the gonads, and gonads are organs that produce the gametes, the sex cells. In males, The testes produce sperm, and in females, the ovaries produce eggs. Genitalia. While all reproductive organs can be called genitalia, the term is most commonly used to refer to the male and female external sex organs. Accessory organs. These organs include the ducts and chambers that make up the tracts connecting the gonads with the genitalia. Other accessory organs are glands that secrete fluids to protect, transport, or facilitate the movement and joining of gametes. Hormonal control process. Both the male and female reproductive systems are stimulated and controlled by the endocrine system. In a two-step process, the hypothalamus stimulates the anterior pituitary to release two gonadotropins, follicle-stimulating hormone, or FSH, and luteinizing hormones, or LH. In turn, these hormones stimulate the gonads to produce gametes and sex hormones. Interestingly, even though the same gonadotropins are released in both males and females, their name describes their function within the female reproductive system only. Let's now consider the male reproductive system. The primary reproductive organs in males are the testes. A complex network of ducts and tubules plus a number of secretory glands make up the accessory organs. The penis and scrotum are the external genitalia. The testes, also called the testicles, are paired oval-shaped gonads that lie within a supportive external sac of skin called the scrotum. Each testes is surrounded by a fibrous connective tissue capsule that extends inward to divide the gonad into 200 to 300 small compartments or lobules. Within each lobule are 1 to 3 tightly coiled tubes called seminiferous tubules, which produce the male gamete sperm. A group of specialized cells called the Sertoli cells line the seminiferous tubules. These cells nourish developing gametes, produce a fluid for the transport of sperm, and play a role in regulating sperm production. Since the optimal temperature for sperm production and survival is a few degrees below the normal core body temperature of 98.6 Fahrenheit degrees, the testes are located externally. The testes also function as endocrine glands. When stimulated by LH from the anterior pituitary, the Leydig cells located between the seminiferous tubules secrete testosterone. Testosterone, along with SSH from the pituitary, stimulates the production of sperm. Testosterone is responsible for the development of the male genitalia at puberty and the development of secondary sex characteristics such as enhanced muscular and skeletal growth, deepening of the voice, thickening of skin, and development of facial and body hair. And here we see illustrated the testes. Illustration A shows the testes, which are located inside a protective sac called the scrotum. In illustration B, we see a cross-section of seminiferous tubules, shows the sperm and Sertoli and Leydig cells. And in illustration C, the micrograph shows the tails of mature sperm cells projecting into the lumen of the seminiferous tubule. Now let's consider the accessory organs of the male reproductive system. Sperm leave the seminiferous tubules and flow into an extensive duct system that stores and transports them. As they move through this network of ducts, various accessory glands secrete fluid that provide nutrition and protection. This combination of sperm and secretions forms a thick whitish fluid called semen. The spermatic duct system includes the epididymis, vas deferens, ejaculatory duct, and urethra. The accessory organs that produce and secrete the liquid components of semen include the seminal vesicles, the prostate, and the bulbourethral organs. Now let's consider the duct systems. The production of sperm and fluid within the seminiferous tubules of each testicle eventually creates enough internal pressure to force the contents out into a tightly coiled segment, the epididymis, which hugs the posterior lateral side of each testes. Sperm mature in the epididymis, developing their motility and ability to fertilize a female egg. While this maturation process takes about 10 to 14 days, sperm can be stored in the epididymis for several months. During sexual arousal, peristaltic contractions of smooth muscle propel sperm into the inner duct, the vas deferens. The vas deferens is a larger and less convoluted tube that carries sperm out of the scrotum and up and over the posterior side of the bladder. At this point, connective tissue wraps the vas deferens together with nerves, blood, and lymph vessels to form a bundle cord known as the spermatic cord. The vas deferens can also store sperm for several months. During sexual arousal, smooth muscle in the walls of the vas deferens contracts to forcefully propel sperm through the ejaculatory ducts and urethra. The ejaculatory ducts pass through the prostate gland before merging into the urethra. The forceful ejection of semen from the urethra is called ejaculation. Now let's consider the accessory glands of the male reproductive system. There are several accessory glands that secrete liquid portions of semen. About 60% of this fluid is produced by the seminal vesicles, which lie between the bladder and rectum. This pair of glands secretes a thick alkaline fluid that helps to neutralize the acidic pH inside the urethra. This fluid also contains fructose, which sperm catabolize for ATP, and prostaglandins, which support sperm motility and viability. The seminal vesicles secrete their fluid into the vas deferens, where it joins the ejaculatory duct. The prostate is a donut-shaped gland that encircles the upper portion of the urethra. During ejaculation, the prostate secretes a milky fluid directly into the urethra. This prostatic fluid makes up about 25 to 35% of semen and contains several substances that support sperm mobility and ensure the semen does not clot or congeal. Two additional secretory glands, the bulbourethral glands, are situated inferior to the prostate on either side of the urethra. These pea-sized glands produce a clear mucus-like substance that lubricates the lining of the urethra to protect sperm during ejaculation. The secretion from the bulbourethral glands, also called the Cowper's gland, is also quite alkaline, which helps to neutralize any remaining acids from the urine. The penis contains the urethra, which serves as the passageway for both urine and semen. As a copulatory organ, The primary function of the penis is to deliver sperm into the reproductive tract of the female. It consists of three segments. The root is the point where it attaches to the underside of the bony pelvis. The middle portion is the shaft or body, and the distal portion is the head or glans penis. The shaft consists of three fascia-covered cylinders of spongy erectile tissue divided into multiple compartments by thin walls of smooth muscle and elastic connective tissue. During sexual arousal, parasympathetic stimulation leads to relaxation of the smooth muscle in the erectile tissue, allowing large quantities of blood to flow into the compartments and fill the erectile tissue within the fascial cylinders. When the tissue is engorged with blood, it causes the penis to enlarge and stiffen, creating an erection, which helps the penis to penetrate the vagina during intercourse. Let's now consider the manual therapy applications. Because the smooth muscle surrounding the erectile tissue is under parasympathetic control, a male may experience an erection during a manual therapy session as part of a relaxation response rather than a sexual arousal response. Understandably, this can be a source of consternation and embarrassment for the client, therapist, or both. Generally, some type of acknowledgement or response by the therapist is required. While there is no single correct way to mediate this situation, therapists who use techniques that focus on relaxation must be prepared for this possibility. Therapists should consider their history and communications with the client, as well as their own personal and professional boundaries, to determine how to tactfully and respectfully handle this occurrence. Time now for our first What Do You Think segment. And remember, the What Do You Think segments are geared towards getting your mind in gear for clinical reasoning skills. What positive or negative impact do the stress reduction and general relaxation effects of manual therapy have on the reproductive system? Why does this occur? If a couple is having difficulty conceiving, the male may be advised to wear looser fitting boxer shorts instead of tight fitting underwear. Why would this be helpful? The female reproductive system is well designed to conceive, carry, and nourish a developing fetus and deliver offspring. Organs include the ovaries, fallopian tubes, uterus, and vagina, which collectively make up the female reproductive tract. In addition to these components, the mammary glands, or breasts, are considered accessory reproductive organs. While breasts develop at puberty, they produce milk only after childbirth, when prolactin from the anterior pituitary stimulates milk production and oxytocin from the posterior pituitary enables milk release. And in our diagram, we see a sagittal section of the female reproductive system. Each female gonad, or ovary, is about the size of a large peach pit. Situated on either side of the pelvic cavity, the ovaries are held in place by ligaments that attach to the abdominal wall and uterus. Similar to the testes, the primary function of the ovaries is production of gametes called the eggs or ova. The singular form is ovum, which is Latin for egg. There are thousands of eggs in the ovaries, each held within a protective ring of specialized cells called a follicle. Approximately 1 month, FSH, from the pituitary stimulates several follicles to ripen or mature together, each with an ovum inside. Generally, only one of these follicles migrates to the edge of the ovary and ruptures to release its egg, a process known as ovulation. Once the egg has been discharged, the remaining follicle is transformed into a glandular mass known as the corpus luteum. The mature follicles and eggs that do not get released disintegrate inside the ovary, and the cycle begins again. When stimulated by gonadotropins from the anterior pituitary, the ovaries also produce the sex hormones estrogen and progesterone. Like testosterone in males, estrogen stimulates the development of the reproductive organs and the secondary sex characteristics at puberty. In females, these secondary characteristics include enlargement of the breast, hair growth in the axilla and pubis, widening of the pelvis, and increased subcutaneous fat deposits in the hips, thighs, buttocks, and breast. Estrogen is also necessary for the onset of the menstrual cycle. Progesterone is important to supporting development of the uterine lining needed for egg implantation and development. Now let's consider the female reproductive system, and we will look specifically at the female genitalia. The external female sex organs are collectively referred to as the vulva. Just superior to the vulva is the soft mound of fatty tissue over the pubic bone, the mons pubis, which literally translates as pubic mountain. After puberty, the mons pubis is covered with pubic hair. The region between the mons pubis and anus is called the perineum. In males, the perineum is the region between the scrotum and the anus. Soft tissue folds called labia surround the vaginal area and the urethral orifices. The larger folds are the labia major, while the labia minor are the smaller folds immediately medial to the labia major. These protective folds over the vaginal opening help keep microbes out, but easily separated for intercourse. The vestibular glands are two mucus-producing glands located in the rims of the vaginal orifice, and they secrete large amounts of mucus during sexual arousal to assist in penile penetration. At anterior junction between the two sides of the labia minor is a small bud of highly sensitive tissue called the clitoris. The clitoris can be compared to the shaft of the penis because during sexual intercourse and sexual arousal, it too becomes engorged with blood, making it firm and erect. Females have three major accessory sex organs, beginning with the fallopian tubes or oviducts, which carry the eggs from the ovaries to the uterus. Attached to the superior aspect of the uterus, these two short muscular tubes extend laterally and end at the ovaries in a cup-shaped terminal portion with multiple projections called fimbriae. These projections surround the ovary to catch an egg as soon as it is released, and they wave rhythmically to direct the captured ovum into the body of the fallopian tube. Once inside, the ovum is moved toward the uterus by way of the peristaltic action created by smooth muscles in the fallopian tube walls. Ciliated cells in the lining create a waving motion with each muscle contraction to gently guide the ovum toward the uterus, a trip that takes approximately 5 days. The lining of the fallopian tube also has a large number of non-ciliated cells that secrete a fluid to keep the egg moist and healthy and to further facilitate movement. The uterus or womb is a pear-shaped organ with thick muscular walls and a small internal cavity. It is situated posterior and slightly superior to the bladder in the pelvic cavity. During pregnancy, when the uterus shelters a growing fetus, it expands to rest on top of the bladder. Structurally, it has three sections: the superior dome-shaped aspect called the fundus, the broad central region called the body, and the narrow inferior section called the cervix. The lining of the uterus is a vascular mucous membrane called the endometrium. During the female reproductive cycle, hormonal signals cause the endometrium to thicken in preparation for implantation of a fertilized egg. If this does not happen, the lining dies, forming a mixture of dead cells and blood that is sloughed away as menstrual flow. At the time of childbirth, the muscular contractions of the uterus provide the force needed to push the fetus through the birth canal. The vagina is a wide muscular tube approximately 4 inches, 10 centimeters long, situated between the bladder and the rectum. It connects the cervix of the uterus with the exterior environment. Sperm is ejaculated into the vagina during sexual intercourse, and babies are delivered through the vagina, which is why it is also called the birth canal. Because the vagina opens to the exterior environment, it has a mucous membrane lining contiguous with the linings of the uterus and the fallopian tubes. This explains why vaginal infections and sexually transmitted diseases such as gonorrhea, if untreated, can spread into the pelvic cavity. Now let's take a look at the female reproductive system menstrual cycle. Although the reproductive systems of both sexes are controlled by the same hypothalamic and pituitary hormones, the cyclic nature of these processes is unique to females. Throughout their reproductive years from puberty to menopause, the reproductive system goes through a series of predictable patterns of changing hormone levels, production of ovum, and shifts in the vascularity and thickness of the uterine lining. The female reproductive cycle or menstrual cycle represents the sequencing of these combined changes. Although the length varies, the average menstrual cycle is 28 days long and is divided into 3 phases: menses, proliferation, and secretion. Menses is the first day of the cycle and the onset of menstruation, the bleeding caused by the sloughing away of the uterine lining. If the ovum has not been fertilized, both the egg and the corpus luteum die, leading to decreased levels of estrogen and progesterone. Without the support of secretions from the egg and corpus luteum, the endometrium cannot be maintained and menstrual flow begins. In most people, menstruation lasts 4 to 5 days, but this can vary based on health conditions and other factors. The proliferation phase. In day 6 through 14 of the cycle, increased levels of estrogen signal the endometrium to grow or proliferate. Estrogen is secreted from the follicles as they grow and mature inside the ovary. High levels of estrogen during this phase lead to a thickening of the endometrium and an increase in the vascularity. Estrogen also facilitates the passage of sperm by thinning the cervical mucus. The secretion phase. The secretion phase begins between days 15 to 28 and it begins with ovulation and ends with the onset of menses. While the exact timing of ovulation can vary, it generally occurs on day 14. The corpus luteum continues to secrete small levels of estrogen after ovulation, in addition to large amounts of progesterone, which stimulate the endometrial changes needed for egg implantation. In addition to a general thickening and increased vascularity of the endometrium, high levels of progesterone stimulate the endometrial glands to produce a nutrient-rich fluid that supports the growth of a fertilized egg. If the egg is not fertilized, menstruation occurs and the cycle begins again. Time now for our second What Do You Think segment. How are the uterus and stomach similar in terms of their structure and function? Which structure in the digestive system would you consider comparable to the fallopian tubes or the oviducts, and why? We will now discuss pregnancy and childbirth, and in the subsequent slides we will look at fertilization and implantation, pregnancy, and childbirth. Let's specifically look at fertilization and implantation. In addition to timing issues, fertilization depends on the number of sperm and their healthy motility. During intercourse, healthy males ejaculate millions of sperm, which travel up the female reproductive tract into the fallopian tubes. Vaginal and uterine contractions assist sperm in their upward movement. If intercourse occurs at the time of ovulation, chemicals emitted from the ovum help to attract the sperm. Even with this assistance, it is estimated that only 100 or so of the millions of ejaculated sperm contact the ovum, which usually occurs in the upper third of the fallopian tube. When sperm bump against the ovum, they release enzymes that break down the egg's protective outer covering. Eventually, one completely breaks away and breaks through and enters the ovum. At this point, the fertilized egg or zygote undergoes changes in its cell membrane that prevent any other sperm from entering, ensuring that only one complete set of DNA is created. This means that conception is more complex than sperm meeting egg. It is the joining of genetic material between male and female gametes. After conception, the zygote continues its trip along the fallopian tube toward the uterus. As it travels, it undergoes rapid mitosis to form a multicelled mass called a blastocyst. The blastocyst has an outer ring of cells surrounding an inner cavity. This inner cavity contains a mass of cells clustered to one side. This rapidly growing mass of cells secretes a hormone similar to LH called human chorionic gonadotropin, or HCG. This essential hormone stimulates the corpus luteum to continue producing estrogen and progesterone to maintain the uterine lining and prevent menses. Between the 4th and 7th days after conception, the blastocyst burrows its way into the endometrial lining, a process called implantation. While pregnancy begins with fertilization and implantation, the entire prenatal period is 38 to 40 weeks. Development begins with continued mitosis and adaptation of the blastocyte. The inner mass of cells develops into the embryonic layers of the ectoderm, mesoderm, and endoderm, which differentiate to produce the various cells, tissues and systems in the body. The ectoderm gives rise to the integumentary and nervous systems, the mesoderm to the muscles and connective tissues, and the endoderm to the internal organ systems composed of the mucosa and glandular epithelium, as we discussed earlier. The internal cellular mass of the blastocyte also produces the amniotic sac, which will surround and protect the embryo. The outer layer of the blastocyte produces extensions that become invested in the endometrium and eventually form the membrane called the placenta. By week 3 of gestation, the developing tissue mass, now called an embryo, becomes attached to the placenta via the umbilical cord. By the end of week 8, the rudiments of every organ system have developed. Beginning in the 9th week, the developing offspring is referred to as a fetus. Blood flows through the placenta, which serves as a protective barrier that provides oxygen and nutrients for the fetus and carries away fetal waste products. The placenta begins to secrete its own gonadotropins so that eventually the corpus luteum of the ovary becomes inactive. And for the next 30 weeks, the fetus continues to grow and develop. The mother's body undergoes extensive changes to nourish and support the fetus as it develops. For example, during gestation, the mother's plasma volume increases by 30 to 50%. Maternal heart rate and blood pressure must increase to circulate this additional fluid load. At the same time, the red blood cell mass increases by only 18%. With the lowered hemoglobin levels and the increased demand for oxygen required by the fetus, the mother's respiratory rate also increases. Kidney function also increases to process the additional fluid and fetal waste, and pressure on the bladder from the growing fetus increases the frequency and urgency of urination. The excessive levels of reproductive hormones needed to sustain pregnancy and prepare the mother's body for birth often cause bouts of nausea or vomiting known as morning sickness. While pregnancy-related changes are natural and positive, they place a tremendous amount of structural and systemic stress on the mother's body. At the end of a full-term pregnancy, the fetus has grown to occupy a space from the pubic bone to the xiphoid process, compressing the liver, spleen, and intestines up against the diaphragm. This compression reduces the mother's lung volume, creates constipation, and may result in heartburn due to acid reflux. The mother's center of gravity has shifted forward, placing stress on the lumbar spine. The skin and protective tissue over the abdomen are distended, causing stretch marks to appear. This stretching of the abdominal muscles also increases stress on the spine, which can lead to low back or hip pain. Additionally, the breasts grow larger and prepare to produce milk for the newborn baby. And here we see illustrated the structural and systemic stressors of pregnancy. The impact of a full-term pregnancy on the structures and systems of the mother is shown. Let's now consider the manual therapy applications with respect to pregnancy. Most manual therapists will work with a pregnant client sometime during their professional career, so all therapists should be familiar with the special considerations, indications, and contraindications for therapy that pregnancy presents. It is a good practice for pregnant clients to discuss the benefits of massage with their physician or midwife before the initial manual therapy session. In addition, therapists should be carefully screening their clients and identify high-risk situations in which therapy might be contraindicated or require specialized advanced training. And some of these high-risk factors include age under 16 or over 35, diabetes or heart disease, history of miscarriage or multiple abortions, pregnancy with twins, triplets, or multiples. If the mother is healthy enough to receive manual therapy, adaptations in normal bolstering, positioning, and techniques are required. Generally, side-lying, semi-reclining, or seated positions are required for safety and comfort. Pregnant clients may need to be assisted on and off the table, and unscented oils and lotions are generally recommended. Therapists must be watchful for excessive edema and varicose veins and treat these as local contraindications. In the second and third trimesters, the risk of blood clots in the lower extremities is high, so deep work, particularly over the medial aspect of the legs, should be avoided. Throughout the pregnancy, deep abdominal work and aggressive or heavy pressure over joints and tendons are contraindicated. Now let's consider childbirth. Birth most often occurs within 2 weeks of the estimated due date. As this date approaches, the fetus shifts into a head downward position and the uterus becomes more sensitive to stimulus. Labor, the sequence of actions that push the baby through the birth canal, begin with regular contractions of the uterus and rupturing of the amniotic sac. The birth process can be divided into 3 stages. Descent and dilation. This is the stage that begins with the onset of uterine contractions. Simultaneously, the cervix begins to efface, which is thin and shorten, and dilate to permit the baby to pass through the birth canal. The stage is complete when the cervix is fully dilated at approximately 4 inches, which is 10 centimeters. Birth. Beginning with the complete dilation of the cervix, this phase is completed when the baby emerges from the birth canal. At this point, the baby takes its first breaths and the umbilical cord is cut to physically separate the mother and child. Expulsion of the placenta. Within minutes of the baby's birth, the placenta separates from the wall of the uterus and is expelled along with the remaining fetal membranes. Time now for our third and final What Do You Think segment. Even though expectant mothers are eating for 2, why do you think they generally prefer to eat small meals? At this stage of your education, what are your chief concerns about working with pregnant clients? How can you best resolve these concerns? Now let's discuss aging and the reproductive system. In both sexes, reproductive development generally starts sometime after age 10. The reproductive system becomes fully active at puberty and sexual reproduction becomes possible. In females, puberty is marked by menarche, the first menstrual cycle, and the beginning of the reproductive cycle. Between the ages of 45 to 55, the follicles in the ovary are exhausted and the ovaries become less responsive to the gonadotropic hormones. This leads to a dramatic decrease in estrogen levels and the eventual cessation of the menstrual cycle. Menopause is the permanent cessation of menses, defined as the point when a person has had no menstrual period for 12 consecutive months, and the end of fertility. Perimenopause is the interval, 3 to 5 years or more, during which a person's body experiences hormonal changes and transitions to menopause. Fluctuating hormone levels and declining estrogen cause irregularities in the normally predictable menstrual cycle and changes in the reproductive organs. While menopause is a natural process, some common symptoms may occur, including hot flashes, night sweats, vaginal dryness, weight gain, insomnia, mood swings, and hair loss. People may experience some or all of these symptoms, and for some, they can be quite intense. But for those who, for the most part, experience menopause, it is usually quite manageable. Since estrogen plays an important role in calcium absorption, the risk of osteoporosis is significantly higher for postmenopausal people. For this reason, many healthcare practitioners encourage their patients to have bone density scans in their early 40s to establish a baseline and gain and again at the onset of menopause. Age-related changes occur later and are generally less noticeable for males. While gonadotropin levels remain high, testosterone levels decrease dramatically between the ages of 50 and 60, and this decrease may start as early as age 35. This decline in testosterone leads to decreased desire for sexual activity, smaller amounts of viable sperm, and a decrease in the mass and strength of skeletal muscles. A common condition for people in this age range is an enlargement of the prostate gland called benign prostatic hyperplasia, or BPH. In BPH, the prostate can grow up to 4 times its normal size and obstruct the urethra. This increases the urgency and frequency of urination, and it decreases the force of the urine stream and creates a sensation of incomplete emptying of the bladder. For this reason, physicians often recommend including a prostate exam in every annual physical beginning at age 50. Males experiencing any type of urinary changes should see their doctor regardless of age. In this pathology alert, we will be discussing endometriosis. Sometimes endometrial cells implant and grow outside the uterus in the peritoneal cavity, a condition called endometriosis. These cells grow and decay in response to the hormones that control the menstrual cycle. Because decayed cells outside the uterus cannot be shed through menstruation, they stimulate an inflammatory response and eventually become surrounded by fibrous scar tissue. People with endometriosis may experience no symptoms, but these growths, most commonly found in the fallopian tubes, ovaries, bladder, and colon, can cause dysmenorrhea, which is difficult menstruation, pelvic and abdominal pain, painful intercourse, or difficulty with urination or defecation. The most common complaint associated with endometriosis is infertility. This usually results from excessive scar tissue, which causes adhesions in the fallopian tubes or ovaries. Because many people with endometriosis find this condition to be frustrating and stressful, manual therapy for relaxation and stress reduction is indicated. But direct manipulation of the abdominal soft tissues is generally contraindicated, especially during menses. Let's take a look at some of the common menstrual disorders. Painful menstruation is called dysmenorrhea, while many people experience some general discomfort or mild cramping. The symptoms associated with dysmenorrhea are severe enough to keep a person from engaging in regular daily activities for 1 day or more each cycle. Dysmenorrhea is characterized by deep acting pain in the abdominal and lower back and/or sharp pain and cramping in the abdominal pelvic region. Commonly associated symptoms include gastrointestinal disturbances such as nausea, vomiting, diarrhea or constipation, and headaches. Dysmenorrhea can be either a primary condition or a sign of an underlying pathology such as fibroid tumors, pelvic inflammatory disease, PID, endometriosis, or any number of sexually transmitted infections. Manual therapies are generally indicated for reducing pain and stress, but direct abdominal work is contraindicated during menstruation. Amenorrhea is the absence of menstruation. Common causes include insufficient estrogen synthesis due to low body weight or body fat percentage below 9%. Amenorrhea is common among female athletes and dancers because the menstrual cycle is controlled by the hypothalamus and autonomic responses. Emotion, stress, and other psychological factors can also lead to amenorrhea. Okay, so we have reached the end of today's lecture, and for assignment number 16, we're going to be using the Thinking Beyond format. Abdominal massage can cause feeling of vulnerability in clients. Why do you think this occurs? How could you communicate verbally and non-verbally to promote safety and comfort when working this sensitive area? Why does menstruation sometimes cause symptoms such as headaches, back pain, and increased emotions? What factors might cause these symptoms to fluctuate from month to month, and could manual therapy influence their occurrence? Given what you know about the effects of aging has on the various systems of the body, what additional strains might be placed on the body of a woman who gets pregnant at an older age? Now, this assignment is due by this coming Sunday at 11:55 p.m. If you have any difficulty with this assignment, you may send me an email or shoot me a text message. My office hours are always the same, Thursdays from 4 to 6 p.m. And with that, I look forward to receiving your assignments, and I will see you in the next lecture.